Hi, welcome everyone to the Cleft Palate Craniofacial Journal's audio and video podcast. I'm Pat Chibbaro, retired nurse practitioner from NYU. Really happy to be your host for this, and always really happy to podcast papers from one of my favorite teams from CHOP. And I have to say, historically, the very first podcast that I did, which I don't even remember how many years ago it is now, maybe 4 or 5, my first paper was with Dr. Oksana Jackson, and we were both very nervous doing the podcast because neither of us knew what we were doing. And here we are. I told Oksana, I'm going to podcast your paper today. And she said, Jordan, that's all Jordan and Isabel's work. So she gave you the kudos back to you.
Well, it's a team effort, but podcasts are something we're all leaning into. It's so fun to learn when you hear in the voice of people kind of how they think about things. And I think it's making these scientific manuscripts come alive.
Definitely.
So these are awesome.
Yeah, no, I'm really happy to do it. It's a lot of fun for me to, even though I'm retired, to still be a part of you can never leave this world. I'll tell you that. Once you guys are all retired, you'll still be a part of it. But let's get into this great paper. So the paper is Patient-Reported Outcomes of Primary Cleft Rhinoplasty, a Long-Term Assessment Using CLEFT-Q. Lots of authors, want to read them all. Isabel Ryan, Jinggang Ing, Ju-Sung Kim, Philip Tully, Oksana Jackson, David Lowe, Scott Bartlett, Jesse Taylor, Eric Liao, and Jordan Swanson. I'm really happy to have Dr. Swanson and Isabel Ryan to join me to talk about this paper. And Isabel, I know you're a fourth-year med student. And before we got on to this, I was hoping that you might get a residency in New York. Just kidding, but
not kidding.
I'm kidding, not kidding, and I'll put a good word in for you. So thanks so much. I know you guys are busy, but let me just jump in and ask what the question I always ask, and whoever wants to jump in, or both of you, is why did you want to take the time and effort to look at this, and study this?
Isabel, do you want to start?
Yeah. So previous studies by our group, specifically Jenny Ng was the last research fellow who worked on this, and she had found that she did a very elegant study looking specifically at primary rhinoplasty in unilateral cleft lip patients. And she had found that in patients who underwent primary rhinoplasty, there was improved nasal shape and symmetry as assessed by anthropometrics. And specifically, there was decreased columellar deviation angle and improved nostril symmetry. And not only that, but she also found that layperson perception of nasal appearance was actually much improved in patients who underwent primary rhinoplasty, as opposed to those who underwent non-primary rhinoplasty or cleft lip repair only. And so really the goal with this study was to build off that past study and see whether these objective improvements translated into improvements in patient-reported outcomes, specifically within the domain of CLEFT-Q, so using the CLEFT-Q.
Jordan,
just to build on that,
yeah,
I mean, we've been using patient-reported outcomes so much more, and we obviously can't ask an infant right after their primary cleft lip report how they feel about the outcome. But we kind of took a bold step with this one and said, could we actually use patient-reported outcomes to see how people feel about repairs that happened from before they could remember? And how does that affect their disposition? Which is kind of wild when you think about it. It was a bit of a risk to do that. And I think where that keys in also is, to me, the kind of clinical motivation of this. I think a lot of comprehensive teams in the US increasingly migrate towards doing primary rhinoplasty, but what that means is very different in different programs. When I work overseas and there's a lot of constraints of our availability or surgeon experience, it's a lot more of a question of, should we take on a primary rhinoplasty, knowing there might be a little bit more risk to the nose-to-nose nasal growth to scarring in less experienced hands, and there might be less kind of recourse for further follow-up. At the same time, there might be more of a benefit to that primary rhinoplasty in places where this might be the only operation that a child gets as an infant. And so it gave really a motivation to try to understand this.
Yeah, and as I was saying before we got started, I'm sort of like the old dinosaur, where I started in 1988 when we at NYU were doing primary rhinoplasties, but a lot of centers weren't. All the controversy about it. I wonder, what's the state of that now, Jordan? What is it, is it, because I know personally that from my experience, and certainly it's anecdotal, but for many years, those kids that had the primary rhinoplasty did not, just a great percentage of them did not even need an intermediate procedure before the end of their facial growth. And we personally didn't study, how that affected their quality of life. So I was really happy to see this, but I'm just wondering for for those who don't really understand all of this from the surgical perspective, what's the downside of doing, what's the worry about doing the primary rhinoplasty? What is the controversy? What has it been? And where are we now? Like, are more teams doing it more than are not doing it?
Yeah. Only 8 really good questions in that set of questions there, Pat.
Pick
So,
whatever you
y-
want.
yeah, to those a little bit less familiar, the question is really, what do you do with the nose at the time of the primary lip repair? And obviously, there is concern that more fragile tissues with future growth ahead, there can be risks of doing that, especially scars and scarring and open approaches. And what that primary rhinoplasty set of maneuvers is, I think varies a lot by team. I think of kind of 6 parts to it, beginning with the open floor of the nose and closing what could be a nasolabial fistula, or the front of the palate at the time of the lip repair. Going up to more the foundational elements, which is the columella in the middle, the alar base on the side, and the sill in the middle. Those are 3 more parts that can be done. And I think many teams that talk about doing, say, a foundational rhinoplasty or a base of nose rhinoplasty increasingly address those things. And in some ways, those are a bit indistinguishable, I think, from a well-repaired lip. However, as you start to march superiorly, either in a semi-open or an open fashion, to actually manipulate the lower lateral cartilages on both sides, potentially the soft triangle hypotrophy, to pexy up potentially that lower lateral cartilage, to address this, what is called the scroll deformity. All of those things get a bit more variable. And I think for residents, even fellows, depending on training, that stuff can be very intimidating. And so people kind of hold off on doing those early on, thinking very appropriately, these could be addressed later on. But I think, as you pointed out, really beginning in the 1970s, a number of surgical teams started doing this. The challenge with everything we do, obviously, is it can be 10 to 15 years to really see the true results of what we do. And I think cautious surgeons are wary and trying to kind of learn from others what to do. One of the things that is really special at CHOP, one of the privileges I have in co-directing the CLEFT team is working with a number of different surgeon sort of types. Unfortunately, with Dr. Lowe's retiring from his cleft practice this year, which has been an incredible, 4-decade expertise and incredible run.
He's an icon for sure. Amazing.
He
And
is.
such a wonderful person. Great
Yes.
surgeon, lovely person.
Exactly. We now transition another surgeon that had a real experience of kind of what they did. And that
Mhm.
figures into this study, because one of the things that we love studying is where we each do things a little bit differently, and we can compare those differences. And Dr. Lowe's premise, which I think has always been a very good one, is, at the time of alveolar bone grafting, 6 or 7 years of age is a very good time to address the nose, not just manipulating the nasal tissue, but taking a little bit of the cartilage from the iliac crest that's right accessible. We're taking the bone to also use for nasal augmentation. And that is maybe a better investment of time and effort. At 6 or 7 years old, it's generally when kids are starting to notice appearance differences. So maybe a good social time for doing that primary rhinoplasty, or an intermediate age rhinoplasty, kind of at elementary age. And so, again, a few very good surgeons doing things slightly differently lets us study differences. And that was a real special thing about this.
Yeah, the one thing I was thinking, Jordan, about the combining of doing that nasal surgery with a bone graft, and it makes sense. Just it really does make sense. I guess the one thing I was thinking, that's like a whole other conversation, and that's a lot for a kid. I guess I was wondering the recovery for that. When you do the nose and the bone graft at the same time, you've got swelling, you've got and I was wondering, is it, that's a sort of a big hit, no? I mean, and I was thinking about, from taking care of kids who have had, bone grafts and, the recovery for that, but it does so make sense to combine it. And it's the timing, doing one procedure. And I was just wondering what you thought about that.
Well, I think it's kind of either or both. I
Yeah,
would say, with sort of fairly experienced teams that are doing these surgeries pretty regularly during the year, I think those elements of the nose add maybe 30 to 40 minutes of time to the alveolar bone graft surgery.
right,
Likewise, I think that might be a similar amount of time for the primary rhinoplasty with the lip repair. I think, again, for many of us, we don't uh, necessarily distinguish these as separate procedures because there's a lot of overlap between a primary
right,
rhinoplasty and a lip repair at the same time. But one could also argue that 30 extra minutes of general anesthesia for a 6-month-old might be more impactful than for a 6-year-old. So I think they're fairly substitutable. One of the things that Isabel's going to come to, which is pretty cool, is we shouldn't just be thinking about this as either or.
right.
And maybe there's an opportunity for both, and she's going to come back to that.
Yeah, so let's Isabel, let's give the listeners an understanding of your paper. Maybe give us a bit of an overview, and also for those who don't know what it is, to just explain a little bit about what the CLEFT-Q is.
Yeah. So starting with the CLEFT-Q, it's a 119 um, patient-reported outcome measure, or PROM, that's specific to patients who have a cleft lip or palate. And it's very unique in that it is really tailored towards this patient population. So in our study specifically, we were trying to compare patients who had undergone primary rhinoplasty, or PR, versus lip repair only, or NPR. And one thing that was quite challenging that Dr. Swanson just alluded to was the fact that a lot of these patients do go on to require an intermediate age or intermediate rhinoplasty. In order to assess this, we actually split our cohort into separate groups. So we considered NPR versus PR alone. So patients who had no secondary rhinoplasty or intermediate rhinoplasty. And then we also considered patients who underwent both PR and intermediate versus those who underwent NPR and intermediate, in order to adequately assess the differences between these cohorts. And one of our main findings of the study was that in patients with PR and intermediate rhinoplasty versus patients with NPR and intermediate, patients who underwent primary rhinoplasty as well as intermediate showed significant improvements in both their CLEFT-Q nasal scores, so their perception of their nose, as well as CLEFT-Q teeth scores, which we think are a proxy of overall mid-face harmony. And that was a really interesting finding, because that suggests that there's two possible explanations that we really posit in the discussion. And that's whether primary rhinoplasty reduces the severity of the nasal deformity early on, making later surgeries easier and more effective, or having a PR boosts positive self-perception early, so patients start from a better place emotionally and
Mhm.
visually. And intermediate rhinoplasty actually serves as an additive benefit to how they think about their nasal form specifically.
Yeah, I mean, just thinking about working with kids over the years is, kids start noticing the differences in each other at a very young age. And so, as I'm looking at your findings, I wasn't surprised. And what did surprise you? What findings did you have that were surprising, if any?
I think that one thing was that we did not find a significant difference between patients who underwent primary rhinoplasty versus NPR only. However, our major caveat with that finding was that our PR patients had trended towards having higher CLEFT-Q nasal scores,
Hmm.
and we only had 7 patients who underwent NPR without intermediate rhinoplasty. And there was actually a significantly higher percentage of patients who underwent PR who did not need an intermediate rhinoplasty. So we were actually controlling for the least severe patient population.
Hmm.
Um, so it was an unexpected finding, but it did make sense given the limitations of our cohort and the fact that NPR patients overwhelmingly required an intermediate rhinoplasty.
Sure. Jordan, looked like you wanted to jump in.
Well, I mean, this study gave totally the opposite result than I was thinking. And
Really?
let me explain why. Because Pat, I agree with you. Your sort of intuition that like earlier primary rhinoplasty would be
Yeah.
better. But here's what was kind of weird about the study. Remember, we can only do CLEFT-Q in kids that are 8 years old and older,
Right.
right? So we're waiting like 8 years down the road to see what happens. And almost every one of these patients, it's not like they'd had no primary rhinoplasty or nothing. Those who hadn't had a primary rhinoplasty had had an intermediate age rhinoplasty at 6 or 7. So they had a pretty recent surgery on their nose. And I would my hypothesis is that those who'd had a recent nasal surgery and really hadn't had some of that deleterious risk of aging after their surgery might have
Hmm.
had better outcomes. Maybe they'd been feeling a little bit badly or different. Now they'd gotten that surgery that made their nose look really good a year or two before they took the CLEFT-Q. So I thought that was a total boost to the non-primary rhinoplasty cohort. And I thought our findings would show that. And then we'd have to kind of discuss if our intuition was really still the primary rhinoplasty made them feel better, how to control for some of these confounders, right? So
Yeah.
that was how I went into this. And it totally showed the opposite. It showed that the impact of that surgery, long before patients are aware of their self appearance,
Hmm.
had far more impact than
Yeah.
those who had a recent intermediate age rhinoplasty.
Yeah.
And again, Isabel described really well those two potential reasons
Hmm.
for that, but they still cohere around the importance of sort of setting the developmental course as optimally as possible, I think, both from an anatomic and a sociologic slash psychologic standpoint.
Yeah, I just wish that kids who are 3 or 4 could tell like, we could study that, like, we could make them fill out things at an earlier age, because that's the time that parents really do work. I mean, they're sending their kids to preschool. They're sending like,
Sure.
they're not with them anymore, I just remember it, and I think and I guess because I was pretty much surrounded by kids that had that primary nasal reconstruction, and so, I always wish though I could know what that experience was and how that the kids felt about themselves because of that. I just love reading this paper because it brought back so much of, I think, what we on the team are always wondering what we're doing. Is it the right thing at the right time? So
Yeah. Well, and again, I think it's an important time to give a real shout out to the developers of the CLEFT-Q, Ann Klass and Karen Wong, Andrea Cusick, and the broader sort of Q studies in general that have really helped us understand this better. We started instituting this at CHOP about 5 years ago, and it's part of our medical record intake process now. So now we have about 1,500 CLEFT-Q responses among our patients, which actually really starts to let us dial into the data with a lot of fidelity. But one of the sort of gaps that you bring up is one very much on their mind, and I'm actually very encouraged by some current work on some future grant applications to extend that CLEFT-Q tool to earlier ages, and whether that's the kids themselves or the kids with caregiver proxies completing that. I think you're totally right about that.
yeah. So, wanted to just talk now about just your methods, that you were not that you had obviously mostly kids who had primary reconstruction. So, are you thinking? And I think you alluded to this in your discussion or in the limitations. Is it something that, because we know CLEFT-Q is used by teams around the country, and I wonder about looking at doing something like this with teams that are as a multi-center with kids, teams that are still doing a lot of or not doing a lot of primary nasal reconstruction. What are you thinking about in terms of your future work? Because I'm sure there's going to be more built on this.
Isabel, do you want to start?
I think that would be amazing, being able to do a multidisciplinary study, just because I do think one of the big limitations of this paper was the fact our NPR cohort was so small. I think that what we've seen in the literature so far is more and more people are performing PR
Yeah.
almost as a standard of care. So I think that having a true comparison group, either through multidisciplinary studies or being able to just continue this data collection and follow these kids as they get older, maybe that's a possible way of addressing this. But I think that something Dr. Swanson and I've talked about as well is thinking about ways to shorten the CLEFT-Q, which is sort of an ancillary study to this. But I think that that's something that I know that the CHOP group is actively thinking about in terms of how to distill the most critical portions of the CLEFT-Q down just to facilitate easier data collection.
Yeah, I was thinking because even when I do surveys, those are a lot of items, and even for an adult. And so I wonder, and you did mention in the paper that you get sort of this, fatigue factor. And I think for kids too, with their attention. And so I think, that was one of the things that I thought about too. And you definitely identified that. One thing I was thinking, Jordan, was, we used to get kids who came to us after they had their primary surgery that did not include a primary nasal reconstruction. So they were in another institution, they came to us, and then we would do another procedure. So I was wondering about, would you maybe have included kids that came to you who you didn't primarily operate on, but who needed intermediate? So I was thinking about that. I was, making my little notes like, Jordan, what about why?
Yeah. Why didn't you do this? It would have been so much better. No, you're totally right. So here's the challenge, and here's one of my the yin and yang of how I think about primary rhinoplasty. On the one hand, I hope that this study, as well as a couple we've done recently that really show the aesthetic outcome in the eyes of surgeons and lay people of primary versus non-primary rhinoplasty, I hope in many ways this is kind of the final nails in the coffin, really, that the standard of care should be doing a primary rhinoplasty, right? However, what a primary rhinoplasty is very variable. And especially when we're talking about, doing some dissection under a tissue that's not very visible, it's gonna be difficult for trainees to learn. What's the impact of things like nasal stents and sutures that are going to dissolve with time afterwards that play a role in stabilizing that primary rhinoplasty? I'm worried that we go down this route where people are doing more procedures or maybe adding more to what our health system is billing, but we're not necessarily getting impacted that. I think one of the things that's my criticism again is that a lot of studies that talk about primary rhinoplasty, certainly in the first 20 years, it was, a personal experience. Hey, I did this. I'm going to put in a few photos of my best 3 patients out of 100, and I'm going to highlight those few patients maybe relatively that didn't need any more nasal surgery. And no, for instance, controlling for the severity of the cleft that comes in. And that's, we think, a very big part of rhinoplasty outcomes. We need to really be comparing like with like. We maybe accept that, for a patient that has fairly minimal asymmetry of the nostril base, in other words, the nostril width ratio, one marker of severity. For narrower ones, maybe they've had NAM beforehand, for instance, which we know improves that we should expect that the majority of those don't need any future nasal surgery. But for the more severe ones, it's not about, okay, can we get away with a primary rhinoplasty and nothing else? It's the idea that this is going to be additive. And that's one of the themes that comes up in a lot of our research, NAM versus postoperative nasal stenting. Guess who has the best results? Those who have both. And if it was your own child, probably you would want to have both. So it's not about sort of substituting as much as trying to figure out how we can sort of economically add on a few impactful things. So I think how we do primary rhinoplasty and how we figure out which maneuvers are the most effective. I'll give you a little tease, which is one of the things that we're going to share in, I think, the next 3 to 6 months, is that we're finding some certain ratios of how much you need to overcorrect the nose by. And so
the nose, yes.
Yeah, a primary rhinoplasty, even a well-executed one that gives you symmetry right afterwards, is probably not going to give you symmetry 5 years down the road. And that's not something we talk a lot about, but I see you nodding because you've probably seen that. And I think a lot of surgeons know that, but that's not something I'd say many of us are passing on to trainees in a very codified way. So one of the things that we've kind of found some very interesting outcomes on are sort of how much you need to overcorrect by and in what ways to get things as ideal as you can 5 years down the road. So that'll be some fun to come.
Yeah, I think overcorrection and, having been at NYU early on when, with NAM and with, and with distraction, learning about the benefit of, I always remember Dr. McCarthy saying, overcorrection, we got to get that right. We've got to get, and the other thing too is remembering to talk to parents about overcorrection, because the kids come out of the OR and the parents are like, what the heck?
Yeah.
Is this normal? So, and that's one of the things that I learned over the years, and I try to impart on my nursing colleagues. When you prepare parents, you really gotta make them understand why, what it's all about, and why we're doing this to try to get that best outcome. And so interesting. No, your paper was great. It sort of brought me down memory lane. I just absolutely loved it. It was terrific and really important. And I think doing, taking advantage of the CLEFT-Q with all these teams and is such a great thing to be able to do. And I know there are lots of different studies that, that are based on using the CLEFT-Q. So I think it's great. And I wanted to just ask, do you have any other thoughts before I summarize and, read out your paper so that everybody looks at it?
Isabel, what would be some closing thoughts of yours?
I think that, like we've touched on repeatedly, I think patient-reported outcomes are really so important in cleft
Yep.
care, and especially being able to integrate the patient perspective into surgical decision making. I think that that's something that will continue to evolve, and I just can't be thankful enough for being able to participate with Dr. Swanson in this work, because this is something I feel very passionate about.
Wonderful. Jordan, any last thoughts?
It's more of a process thing. You guys have been hearing Isabel, soon to be Dr. Isabel, speak so articulately about this. And, she's just finished her 3rd year, starting her 4th year of medical school. She took a year to do a research fellowship with us. I think a lot of medical students ask me kind of, how do I learn more about this field? And how do I kind of learn more about what I want to do when I kind of, pick a career? And, seeing her really take on this study, really get into the depth of not only what cleft rhinoplasty and what cleft nasal deformities are, but study design, really good data analysis, assessing co-founders, presenting. She presented this work at ACPA this past May and did a terrific job. Watching her grow and take this on and really being excited about her being a future member of our field, I think is a great example of why, it's not quantity, but quality. Taking on a couple of projects to really go deep, to learn about this field is really what's going to push it forward. So I
No.
really want to give some props her way.
No, it was a great job. It was really well done. I was very excited to see your paper. So let me just summarize that this is a paper that is out of one of my favorite places, Children's Hospital of Philadelphia. It is the patient-reported outcomes of primary cleft rhinoplasty, a long-term assessment using CLEFT-Q. You can see it online first. It was posted on July 1st. And the authors are Isabel Ryan, soon. I'm watching for her to be Dr. Isabel Ryan. I can't wait to see where you land. Jingang Ng, Ju-Sung Kim, Philip Tolley, Oksana Jackson, David Lowe, Scott Bartlett, Jesse Taylor, Eric Liao, and Jordan Swanson. I want to thank both Isabel and Jordan for taking the time from your busy schedule to be with me to talk about this paper. Everyone should be looking at this. Anyone that is on a cleft team, surgeon or otherwise, it's really, really important to take a look at this. And I really appreciate your being with me. Thanks so much.
Thanks a lot, Pat.
Thank you, Pat.